Thank you, Dr. Filner, for joining us again, and let's continue our discussion on TMD.
Thank you, Mike. I think one of the things that I wanted to mention today was Ernest syndrome, and every dentist who treats TMD problems should know about this. And if it's not done to evaluate the patient initially, then certainly after several treatments, if the patient is either flared up or is not improving, it's really important to eliminate this as a cause. And it's very easily done by taking your finger and palpating inside the mouth at the angle where the coronoid process of the mandible is and where the temporalis tendon inserts. Ernest syndrome is a significant amount of temporalis muscle or temporalis tendinitis. If that tendon gets very inflamed, this can cause significant facial pain over almost all of the face and upper neck. And it's easily discovered, easily treated with a small amount of cortisone injected right at the area, not into the tendon, but around it, and is usually resolved within several days. The steroid takes at least 2 days to work, so you mix it with some local anesthetic, which will numb it for a while and show you that you achieved the correct diagnosis, and then about the 3rd day is when it really begins to get done. This is something that you should be able to pick up and really do. A similar thing is there is a very short, small ligament which can get inflamed, the stylomandibular ligament. You can use it if it's minor inflammation. You can use the smart laser to aim right at the angle of the jaw, a little bit behind it. And if it's a chronic inflammation, which is not very extensive, the laser should ameliorate it significantly. Sometimes you need a 2nd or 3rd treatment. Most of the time, if a patient doesn't chew hard, if you've done the injection for Ernest syndrome, they shouldn't chew hard things for several days. That rarely comes back. The next thing we need to talk about is looking at jaw deviation when the jaw is opened. If it moves to one side or the other, it's often one of the pterygoid muscles that's involved. And based on my experience in injecting those through the outer edge of that area that the coronoid process makes with the mandible, when you open the jaw slightly, such as this, you feel this opening. I used to inject through that area and would get both the medial and the lateral pterygoid muscles as well as one of the masseter muscles. The single beam probe can give exactly the same results. When you have the patient open the mouth and go right into that area, it will treat both the medial and lateral pterygoid muscles, and you can then check it and see that the deviation of the jaw is decreased or eliminated.
And Dr. Filner, you would generally use what, probably 3 to 5 cycles at each point?
What I've discovered since we worked on the development of this laser, I've been trying 3, 4, or 5 cycles on various trigger points. If a patient sort of grunts a little bit and it's not that tender, 3 cycles can sometimes resolve the problem. 4 will get significantly more trigger points. 5 gets them all. I've basically, if it's a trigger point that you've identified properly, it's going to work. I've inactivated about 175,000 trigger points over these 14 years with this low power laser, and I've only had 4 that I could not do. One was a bodybuilder, had very dense muscles in his pectoral muscle. The other were 3 patients who had very large buttocks, and I needed a 6-inch needle to inject them to inactivate the trigger point. So those are the only 4 I've not been able to inactivate, and using 5 cycles essentially gets every one.
Okay.
So you don't have to go back over and redo it.
Okay. Well, Dr. Filner, anything you'd like to share with our listeners before we call it an evening?
Basically, I think it's really important to be able to examine these patients for myofascial trigger points, because they are invariably at least part, if not all, of the problem with TMD. and therefore will allow you to use the proper splint on the bottom so that the fulcrum for moving the jaw forward is on the immovable maxillary bone. An upper splint just does not work to resolve these problems, at least in my experience. And even though I'm not a dentist, I see a fair number of these cases and work with dentists who use lower splints, and these work to decrease the clenching that patients are doing, which invariably creates these myofascial trigger points.
Well, Dr. Filner, thank you so much for your time, and look forward to visiting with you again in the future. Thank you, Doctor.
Thank you.